I am Dr. Samita Garg, gastroenterologist at Cleveland Clinic, with a focus on motility disorders like irritable bowel syndrome, chronic constipation disorders, and gastroparesis. Joining me today are digestive disease specialists from Cleveland Clinic. We are proud to be recognized nationally as one of the top digestive disease programs. Cleveland Clinic's Digestive Disease Institute provides patients with the most advanced level of medical and surgical care focused on the safe and proven treatment of disorders related to the digestive tract. We are here tonight to answer your questions, share our expertise, and provide clinical insights on the following: when digestive issues require medical intervention, managing short-term and chronic digestive diseases like heartburn, irritable bowel disease, and liver disease, colon cancer screening options and colon health, ways to create or maintain a healthy digestive system, and much more. Today, over 800 people signed up for this event. We had over 200 questions submitted by our audience, so we will do our best to answer as many questions as we can. We will also send out an email after the event that includes other digestive health resources. If you're interested in scheduling an appointment with a DDI physician after the event, please call 216-444-7000. So with all that said, let's take a few minutes to do introductions, and then we'll dive right into the questions and question and answer portion of our event. To kick things off, again, I'm Dr. Samita Garg. I'm a gastroenterologist with specialty in motility disorders. So that includes irritable bowel syndrome, as well as other motility disorders like gastroparesis and constipation. I'm also the moderator for today's event. I've been practicing for 10 years. I'm located at Cleveland Clinic main campus in Cleveland, Ohio. Some of the most common issues that I see in clinic include patients with chronic constipation that have tried different things over the counter. They've tried different dietary therapies and they continue to have symptoms. So a lot of patients also experience constipation when they travel or when they have challenging schedules with work. Other disorders that I see include pelvic floor disorders like fecal incontinence. And then the other major issue that I see is something called gastroparesis, where the stomach doesn't empty and the contents don't leave the stomach as well as they should. And one of the most common causes for this is diabetes, and we have different treatments for this. Next on the panel, I'd like to introduce Dr. Rebecca Gunter.
Thank you, Samita. I'm Rebecca Gunter. I'm a colorectal surgeon practicing primarily at Hillcrest Hospital on the east side in Mayfield Heights. I did my fellowship at the main campus in Cleveland Clinic and have been here ever since. The things that I see in my clinic are disorders that sometimes require surgery, and that can include colorectal cancer, diverticulitis, constipation, fecal incontinence, and then I also do things like hemorrhoids, anal fissures, anal fistulas, and then I also perform screening colonoscopies. So practicing a sort of a full breadth of colon and rectal care for a wide variety of patients.
Thank you, Dr. Gunter. And something I forgot to mention is Dr. Gunter and I work together. A lot of us work together and have combined clinics that we offer to a lot of patients so that they can be seen in a multidisciplinary fashion. So next is Dr. William Papouras.
Yes, thank you, Dr. Garb. My name is William Papouras. I'm a general surgeon. I'm located at our Cleveland Clinic Akron campus in Akron, Ohio. I've been in practice here for about 22 years now. I spend half my time taking care of heartburn patients in our heartburn center, which we developed over 10 years ago now. And I also spend the other half of my time taking care of general surgery patients, gallbladder, hernias, lumps and bumps, and those types of issues. And we do see a fair share of patients with heartburn.
Thank you, Dr. Papouris. Last but not least, we have Dr. Jamile Wakim-Fleming.
Thank you, Dr. Garg. Yes, my name is Jamile Wakim-Fleming. I'm a liver specialist, board certified in transplant hepatology, and I focus so what does that mean? So I see patients who have end-stage liver disease such as cirrhosis, who are about to get into liver transplant. So we take care of these patients, get them ready for the surgery. I also started the Center for the Metabolic Steatosis of the Liver, and that means the fatty liver disease, the Center of Fatty Liver Disease, which is no longer called fatty liver. It's called the Metabolic Steatosis of the Liver. So I direct that center, and my practice is also focusing on taking care of these individuals to help ease the burden of the fatty cells on the liver and prolong their life and delay the need for transplantation and delay the development of cirrhosis in those individuals.
Thank you, Dr. Wakim-Fleming. A very important area. And thank you for all the introductions. Now it's time to answer your questions. Again, we received over 200 questions, so we will do our best to answer as many as possible. We have consolidated some of the questions to be able to answer more questions. We have a wide variety of topics, so that includes colonoscopies, reversing fatty liver disease, treatment options for heartburn, chronic constipation, and many more. So we'll spend about the next 45 minutes answering these questions. The first question is for Dr. Gunter. At what age, Dr. Gunter, should one begin to have a colonoscopy, and at what age can you stop?
It's a great question, very commonly asked one. Several years ago, we moved the starting age of colonoscopies from 50 down to age 45, in part because we have started seeing a larger number of young patients coming in with colon cancer. And so we started recommending screening at age 45 several years ago. That's for the standard population at typical or average risk. There are a number of things that would move that date earlier. So one of those would be a family history of colon cancer or high risk or advanced polyps. And so typically we would say you start at age 45 or 10 years before the member of your family who was diagnosed with colon cancer at the age of diagnosis. So if your father was diagnosed with colon cancer at age 50, we would recommend you have your first colonoscopy at age 40. And then there are other things like if you have a history of inflammatory bowel disease or other things like that would move the age of starting colonoscopy to an earlier date. So part of that is in discussion with your primary care physician or your other providers to decide when you should start your screening colonoscopy. But for the average person, it's at age 45. And then when to stop screening colonoscopy is a bit more of a difficult question. It's not as clear. Again, we say generally we can stop doing screening at age 75. And that's partly because the risk of a procedure increases with age, things like risk of having sedation or anesthesia for the procedure, risk of bleeding, the risk of the prep for the colonoscopy being more challenging on older patients. But having said that, in the age of between 75 and 85, that's very much a case-specific discussion between you and your provider based on your history of have you had polyps on a previous colonoscopy, and what is your health status at that time? As people are living longer and healthier lives, it makes sense in some patients to screen past the age of 75, given various health factors or, again, your history of polyps. And so generally, we say we can stop screening at age 75. But again, that's a discussion to have with your provider and with the person who's performing your colonoscopies to decide whether you should continue screening past the age of 75.
Thank you, Dr. Gunter. Yes, many of us also perform colonoscopies at different locations so that there's different options for patients. The next question is for Dr. Papouris. What causes the burning sensation in one's throat throughout the day and night. And is it acid reflux or what's called GERD, which is a short form for gastroesophageal reflux disease?
Yes, thank you. So this is a very common question that we see as well. So acid reflux is something that occurs when the acid from the stomach comes up into the esophagus, and sometimes it can come up all the way up into the throat. And that's a lot of times what the sensation is that patients are feeling. Acid reflux is something that occurs on a periodic basis, where GERD or gastroesophageal reflux disease is more of a chronic nature. So typically most people will feel some sort of reflux throughout their lifetime. It's the chronic problems that we really need to look into and see what's going on. A lot of times people notice this at night when they're laying down. They might have an associated hiatal hernia, and when they're lying down flat, a lot of the contents comes up and it'll wake them up in the middle of the night. We hear that pretty frequently with patients. They do notice that liquid or burning sensation in the back of their throat.
Thank you, Dr. Paporis. So the next question looks like is for me, which is, do people with irritable bowel syndrome, also known as IBS, have constipation, diarrhea, or both? So actually, patients with IBS or irritable bowel syndrome can have any of the above. They can have constipation, they can have diarrhea, or it can be a mixed type where they can alternate or change over their lifespan. I just saw a patient today that when they were younger, they started out with IBSD, or irritable bowel syndrome with diarrhea predominant symptoms. Over the years, they evolved to having more constipation predominant symptoms. One of the main things that defines IBS is some kind of abdominal discomfort or pain and bowel movements that are associated with that discomfort. Meaning if they have a bowel movement, that discomfort can be relieved, or sometimes when they have that bowel movement, it may elicit pain. So basically, IBS is a syndrome. It's considered a chronic syndrome or chronic disease that has been occurring at least over the past 6 months, defined by pain or discomfort in the abdomen and some kind of alteration in their bowel movements. And depending on, and we'll get to this in one of the other questions, depending on what patients have and what they present with and what their symptoms are, we guide treatments based on that. So the next question is for Dr. Gunter about diverticulitis. What do you need to do to manage diverticulitis?
So it depends a little bit on what the presentation of diverticulitis is. So to back up, on patients who get screening colonoscopies after the age of 50, we will see diverticula or outpouchings within the colon in over half of those patients, and that is called diverticulosis, just the presence of having the diverticula. Again, that's very common, but only around 4 to 5% of those patients will ever develop diverticulitis. So we don't get too excited about patients who have diverticulosis because it's very common and rarely causes a problem. Diverticulitis then is inflammation or infection of those outpouchings. And that can range on a spectrum from uncomplicated disease where patients have some pain, maybe have a fever, some disruption in their bowel habits, but will resolve sometimes with antibiotics, but we're also moving away from giving antibiotics in the uncomplicated setting because we've learned that many patients will do fine without antibiotics. And then there's a range of more severe disease that will typically end up requiring an operation depending on the severity and frequency of episodes. We used to tell patients many years ago to avoid popcorns and seeds and nuts and things like that. But after doing large studies, we've learned that doesn't really have an impact. So I tell my patients to pay attention to their own food triggers. And if you find that eating popcorn and seeds and things like that make your symptoms worse, then you should avoid them. But if those don't bother your symptoms, then you can go ahead and eat them. And then pay attention to other foods that may cause more symptoms. You can talk with your doctor about whether the frequency of your episodes and severity of them warrants a surgical evaluation to talk about whether you are a good candidate to have part of your colon removed that is the culprit for your diverticular episodes. It's typically in the sigmoid colon. And if your symptoms are not significant enough or often enough that warrant a surgery, the other thing that I always stress to my patients is to make sure that you're up to date on a colonoscopy, because we do know that diverticulitis episodes can be associated with malignancy or other underlying issues. And so that's what I would always recommend patients to get updated on their colonoscopy.
Thank you, Dr. Gunter. Definitely very important if patients have questions about diverticulitis or colonoscopies to direct that to their physician or their GI doctor. The next question is for Dr. Papouris. Are proton pump inhibitors, also known as PPIs, some of the common ones you may have heard of include Prilosec and Nexium. Are those medications really the best way to control reflux or GERD, or are there other options for treatment?
The proton pump inhibitors are very effective in controlling symptoms of GERD. They do decrease the amount of acid that's produced. So you're still having the reflux occurring, but it's not symptomatic because the acid isn't as prevalent. It's not our only medication that we have, but it's the most common one, and we see people on it very commonly. Other medications are H2 blockers. An example, the generic version would be famotidine, or Pepcid as it's mostly known. Also, over-the-counter Tums are helpful as well. Also, when we see patients, we really look at lifestyle and try to modify lifestyle factors to help decrease the amount of GERD patients are experiencing. Caffeine, carbonated beverages, alcohol, and tobacco, and chocolates all increase reflux, and we try to work with patients to mitigate those types of factors. Some patients that are overweight help with weight loss to help mitigate factors of reflux as well.
Thank you. And looks like I unintentionally skipped over Dr. Wakim-Fleming. So Dr. Wakim-Fleming, very important question for you. Is it possible for someone who doesn't drink to develop fatty liver disease? Or is fatty liver disease only caused by drinking?
Dr. Gag, this is a very important question. Almost 95% of the patients that walk in my office ask me the same question. They say, how come I have fatty liver and I don't drink? There are many conditions that cause fatty liver, and I should say fatty liver is replaced now, I should emphasize that, by the word steatosis. And I'm going to explain what happened back in May and June of this year, 2023. Multiple society, including the Spanish, the American, and the European societies of liver disease, in addition to experts from 36 countries in the world, patient representative, about maybe 260 people on the panel got together and decided that the word fatty liver or non-alcoholic fatty liver is no longer acceptable, and they replaced that term with metabolic steatosis or steatosis of the liver. So this is a term that most patients are going to hear and see in the note, because we have replaced the word fatty liver when we write notes, and it's going to be like that, coded as steatosis. So it's something to be familiar with. So steatosis is the presence of the original term of fat cells in the liver. And it's a big term. It includes the metabolic features. So the first thing I tell my patient, and I look at their record and see if they have metabolic features. What does it mean, metabolic features? Metabolic features means that they either have high blood pressure or their weight is excessive. The waist circumference is more than 40 inches for men or 35 inches for women. They have high triglyceridemia. When the doctor check their lipid panel, there is abnormalities there. The triglycerides are high, the HDL is low, and they have diabetes or prediabetes and high blood pressure. So if they have at least 2 or 3 of those, then they have the metabolic feature. If I see that in addition to steatosis, and the steatosis is seen in the ultrasound, right? This is the first screening. They come to me screened by their primary care doctor. They do an ultrasound for pain or for some other condition, and here their reading says steatosis of the liver. So I put all of these together and say, yes, they are at risk. So if I'm going to go back to your question, does alcohol cause steatosis, or is only one? Absolutely not. A lot of people don't drink, and then they are surprised that they have steatosis. So what causes it other than alcohol? Alcohol definitely is one. Nowadays, alcohol and metabolic features are the highest number two for causing steatosis. So metabolic features, as I explained, the weight, the large circumference, the dyslipidemia, and the blood pressure and diabetes. That's one. Alcohol is one. Excuse me. Drugs. There are certain drugs that causes steatosis in the liver. The most common one are steroids or prednisone. Some people take excessive vitamin A. That does it. Amiodarone to correct irregular heartbeat. So there are drugs, there are a metabolic feature, there is the alcohol, and there are other conditions such as hepatitis C, which was very common up to 10 years ago. Now we see less and less of it. Wilson disease that happens in young people. And I tell my patient rapid weight loss and starvation. So we could gain a lot of weight quickly and lose. Actually, we could gain weight progressively over time, but if we lose weight quickly, that will cause a fatty liver. So there are several conditions other than alcohol. The highest number of liver disease or chronic liver disease that is caused by fatty liver are mostly alcohol and metabolic features. So now we are seeing more people, they have diabetes, obesity, dyslipidemia, blood pressure, and all of that. They are reaching out to alcoholic liver disease, and those two take precedence or are more common than any other condition that lead to cirrhosis of the liver, and cirrhosis of the liver leads to liver failure or liver transplantation if the patient makes it. So to go back on that question, steatosis of the liver or fatty liver is caused by several conditions, and a patient should be, an individual should be aware of that.
Thank you. And just to follow up, since you were answering this question, is fatty liver disease genetic? And what are the treatment options for this?
Yeah, so genetics is something we're still learning. There are reports of a couple of genes that have been discovered, but since we don't screen for genes on every person we see, it's still in the trials and the studies. So we don't know exactly what is the gene, but definitely as we see in families, for example, families who have fatty liver, they are going to have children at risk for fatty liver. So there is some genetic component to it, but it's not very clear yet. But yes, I do say genetic. And we see people who for example, are 250 pounds, 350 pounds, they don't have liver disease. So there is definitely some genetic component to fatty liver disease or steatosis of the liver. What are the treatment options? So depending on the cause of that steatosis, if it's alcohol, absolutely they have to stop. It's okay to drink, but once the liver starts showing damage from the steatosis, we ask them to stop, especially if they have cirrhosis, because fatty liver disease will lead to cirrhosis over time. It doesn't lead to cirrhosis in a day or two. It may take 10 years. But the patient that I see, they are 40 and 50 and 60. They started having fatty liver when they were 30. And back 30 years ago, we did not know much about it. Right? So after 10, 20, 30 years, now they're having a problem with the liver. So the first thing is look at what caused that. What's the etiology? We ask them to stop the alcohol. If they have risk of metabolic features, such as obesity, if they have that disease, and obesity is a disease, it's not a stigma, it's disease. It's a disease like any other disease. We need to address it and treat it. We treat that. If they have high blood pressure, we should treat it. If they have abnormal lipid profile, triglyceridemia or anything like that, we should treat those condition, because up to today, there are no FDA-approved drugs to treat fatty liver, steatosis of the liver. So I cannot give my patient a medication and say, take it and the fatty liver is going to disappear. We are treating all the conditions associated with that steatosis of the liver to help ease the fatty liver, to decrease the fat cells in the liver, and that will decrease the strain because the fat cells are bigger than the liver cells. And so they, in a simple term, they nudge on the liver cells and they cause irritation of the liver, and then the liver will see abnormal liver tests. And when there is about 30% of the liver has steatosis in it, then we see it on the ultrasound. So we treat the conditions associated with the fatty liver or steatosis by treating, by taking care of all these problems. In addition to that, there are medications now, and people should know that, to help. Before I get to medication, so how do they lose weight? By changing their lifestyle, by seeing a nutritionist. Now, if people want to lose 10 pounds or 15 pounds on their own, that's fine. But anytime they are going to lose more than 20 pounds, we advise them to see a nutritionist. And the patient that I see, they all need that, because if you lose weight, you are losing muscle and nutrient. If you want to lose 30, 50, 60, 80 pounds, you are losing a lot of muscle and a lot of nutrients. So I advise my patient, and I actually, in the clinic with me, there is a nutritionist with me that immediately goes from one room to the other to treat them, to talk to them about the diet, and to help them not lose nutrient, and they need to exercise to build the muscle. So these are the simple things. Treating the other conditions, the blood pressure and the lipid and all of that, doing a good lifestyle, changing the diet. And what is the best diet? I think there is a question on that later, but maybe I'll talk about it right now because it flows with it. It's the Mediterranean diet, which is composed of a lot of vegetables and fruit, less meat, and maybe we could come to that again later. I'll talk in detail. But so we're going to do the conservative measures. And then there are medication to help, FDA-approved medication to help lose weight and to help control the diabetes. Several medication, namely, I'm not going to name it right now, but their primary care doctor should know. And when I see patients like that and I think they need medication, I have a discussion and a referral to the care doctor and say, can you please start this and this, or it's okay to start this and this, even though the liver tests are abnormal or there is a little bit of cirrhosis, because we're going to treat them right now before they need a liver transplant or they end up with liver failure and death, or cancer, because fatty liver or steatosis of the liver breeds cancer 5% per year. The other thing that is available, and remember, this entity of fatty liver and steatosis of the liver is kind of like new. So there is so much trial and so much studies and so much. If every few months there is a new paper coming out and then new indication and new guideline. So there is now, in addition to the medication and the conservative measure, we have bariatric intervention. So the Bariatric Society decided that a couple of years ago, it was if the weight, the BMI, basic metabolic, BMI, the basic weight, which is they take the weight in kilograms and divide it by the square of the surface of the body, right? And that's based on the height. So when we do that, we get the BMI. And the BMI varies between 25 and low. 20 to 25 is normal. Above 25, they're a little overweight. Above 30, they're obesity class 1. Above 35, class 2. And above 40, 30. Class 3. So if the BMI a few years ago was more than 40, the Bariatric Society said, okay, then we need to do surgery for these people, because when your weight is that high, you have all the metabolic features. In general, as I said, there are some exceptions, and the surgery not only help with the weight, but it helps resolve the diabetes, the blood pressure, the dyslipidemia, and the conditions that are associated with those are heart disease, heart attack, stroke. This year, the American Society for Bariatric and Metabolic Surgery decided we're going to go to BMI of 35 and above. So they decreased the level. So people who have 35 and above, they recommend to do the surgery. People who have BMI 30 and above, plus any of the metabolic feature, they are very highly suggestive. Like if I see somebody BMI 31, I'm not going to send them to surgery, but I will put them on, we'll do all of this that I talked about, the conservative measure, the lifestyle changes, the exercises, the diet changes. And if they don't lose weight and they don't recover and improve, then we start talking about surgery. There are different kinds of surgeries now. The Roux-en-Y was the older one where they cut the stomach and they bring some of the intestine, bring it up to the stomach and all of that. Now we do the sleeve, which is much, much easier, where they cut the stomach longitudinally and the stomach will look like a banana. So
Thank you so much. Thank you so much, Dr. Wakim-Fleming, for that thorough overview of all the different causes of liver disease, all the different treatments, your nice comprehensive clinic where you often offer nutrition services, medical treatments, surgical treatments, and for an increasingly important area, what's now newly termed metabolic liver disease, and how that's so important, and the management of that is so important in our society today. So thank you for leading the way at the Cleveland Clinic for this clinic. And thank you for answering actually a lot of the audience questions related to liver disease. So next question is, we're going to go back to the colon for Dr. Gunter. Dr. Gunter, what are some of the causes for microscopic lymphocytic colitis, and can it be managed without medications?
So microscopic colitis is an umbrella term that includes lymphocytic and collagenous colitis. They're very similar diseases marked by chronic non-bloody diarrhea in patients who have a normal appearing colon on colonoscopy, but have findings or abnormal findings on biopsies taken during the colonoscopy that show markers of inflammation within the colon under the microscope. Other symptoms other than the non-bloody diarrhea include abdominal pain, fecal incontinence, weight loss, and fatigue. We don't fully understand what causes it. There are a couple hypotheses. One is that there's a dysfunction in the mucosal barrier of the colon that increases the inflammatory response to antigens or irritants in the colon. And it may also be related to alterations in the microbiome. Some risk factors include older age, female gender, a history of other autoimmune conditions, a family history of similar colitis, smoking, and certain medications such as NSAIDs like ibuprofen or Motrin, PPIs that will be used for gastritis or acid reflux, SSRIs or certain antidepressants or anxiety medications, and statins used for cholesterol. The treatment typically involves medication, and it can start with things like antidiarrheals, medications like Imodium or loperamide. The mainstay for treatment of these colitis is a medication called budesonide that is a kind of a steroid that acts only on the GI tract but is not absorbed to affect the body elsewhere. There are some lifestyle modifications you can try that would not involve medications, things like smoking cessation or stopping the medications that I listed, like the NSAIDs like ibuprofen or Motrin, the PPIs, SSRIs, and statins. And then for any patient who is experiencing disruptions in their bowel habits with either constipation or diarrhea of any cause, I always counsel patients to keep a food diary or a bowel diary so that you can try to identify, are there food triggers or things that affect your bowel habits? And if you can identify patterns, then you can try to eliminate those things from your routine. Very rarely is surgery ever indicated for these kinds of colitis. It's really only if the symptoms are truly refractory from all of these other measures. That's what I would say about microscopic colitis.
Thanks, Dr. Gunter. That's something we frequently see in GI, as you mentioned, PPIs, but especially NSAIDs and antidepressants are a couple of the medications we see. The only other thing I would add is I've also seen patients who take herbal medications. We just want patients to ask their doctors about herbal medications and if they need them, because not all of them are benign. So I've seen that as well. The next question, so we're back to the esophagus. This is for Dr. Papouris. Are there surgical treatment options for GERD or reflux or heartburn, more than just medical options?
Yes, we do have several surgical options for GERD and heartburn. If the non-surgical measures and lifestyle modifications went into effect and patients are still experiencing significant reflux symptoms that can't be fully controlled on medications, we do have surgical options for them. Prior to the surgery, do have to make sure that the reflux is truly what's causing everything, and we end up doing an endoscopy, placing a probe that measures the amount of acid that's actually coming up from the stomach into the esophagus. And we do a manometry test, which is a test that measures how the esophagus is contracting to make sure that surgery is going to be effective and helpful and not make certain symptoms worse. The options we have for surgical treatment, the main one is a laparoscopic surgery where we fix any type of associated hiatal hernia. Hiatal hernia is a normal opening in the diaphragm that in some patients gets larger. This is the normal opening where the esophagus comes from the chest into the abdominal cavity, so we'll close that down. Sometimes we have to put a piece of mesh in there to help treat that hernia. And then what we do is we take the stomach and wrap it around the lower part of the esophagus, and that helps create a little bit of higher pressure in the lower esophagus that will control the symptoms of reflux and help patients really either decrease the amount of medications that they're on or to completely get off their medications. We do have another surgical option that is done incisionless that we've been doing down here in Akron for at least 10 years. It's called the transoral incisionless fundoplication. It's a special device that the scope goes through, and through that we can actually take the stomach and use special fasteners and wrap it around the esophagus from the inside. We can't get a full 360-degree wrap because of that. It's a partial wrap, and it is effective in patients. We have to be careful with who we do that on, though, because you can't really do that if someone has a larger hiatal hernia. So if lifestyle modifications aren't effective, we do have surgical options for patients as well.
Thank you, Dr. Papouris. So the next question is about IBS, or irritable bowel syndrome. This is, what are the treatment options for chronic IBS and or IBS flares? So what I would say about IBS is it is overall a very personalized symptom-based treatment strategy to treat our patients based on what each patient needs. So we're very fortunate at the Cleveland Clinic. We have a comprehensive and combined clinic. We have nutritionists that specialize in GI motility and functional bowel disorders like IBS. And we also have GI psychologists that specialize in what's called the brain-gut axis or brain-gut disorders like IBS. So we want to get the full picture with what patients are going through with IBS, because a lot of times they not only have GI symptoms like pain and discomfort, bloating, and bowel symptoms, as I described earlier, but a lot of times they have other symptoms like brain fog, fatigue, just not feeling like themselves, maybe even gaining weight. And so we really try to get the whole picture. What are they eating? What is their routine like? And what are some of the stressors that they may or may not be going through? And then really we do a very personalized treatment approach. So especially in IBS, it depends on what the symptom especially is. And assuming patients don't have red flag symptoms and are up to date in some of the things that, for example, Dr. Gunter talked about, they're up to date on their screening colonoscopy. They've gotten that at 45 years old. They don't have rectal bleeding. and we know that this is IBS, then we focus on some of the things that are really bothering them. So if it's constipation, I'll talk later about some of the constipation medications we give. If it's bloating, we talk a lot about what's called neuromodulators, or medications that affect the nerves and the hormones that are present in the gut. And then if it's diarrhea, we talk about different treatments for diarrhea that can start with things like fiber, changing the diet, or giving medications that slow down motility. So again, it's a personalized treatment approach based on what each patient needs. And we really try to also look at the nutrition aspects, the GI psychology aspects, and if the patients are up to date on any testing they may need, especially any screening tests like a colonoscopy they need. And last but not least, we make sure they're up to date on their thyroid testing and gluten testing, that there's nothing else that could be contributing to their symptoms. So that's the overview of IBS treatment. Then the next question is back to Dr. Wakim-Fleming. Can fatty liver, which as you mentioned, Dr. Fleming, the name is different now, metabolic liver disease, can metabolic liver disease be reversed? And if so, how long does it take? And Dr. Fleming, I think you're on mute.
Sorry.
Thank you so much.
Thank you. Yes, definitely. It can be reversed before extensive scarring happen. And how is it going to be reversed? I already mentioned those earlier, the different treatment modalities, whether it's conservative or medication or surgery. And that's why we want to do it and address these issues right now before it leads to advanced cirrhosis where it may not be reversible. And how long does it take? So how long does it take? It depends what causes it, right? And how rapidly we could improve the other symptoms. So there is no really, it could go from few weeks, few months, and to few years, depending how fast we can treat the other conditions associated. And with surgery, it happens earlier. With medication, it takes a little bit longer time. Thank you.
Thank you so much. So it sounds like earlier is always better, especially if you find out early on that you have fatty liver disease. So
Yes.
that is definitely good to know. So back to the colon again for Dr. Gunter. This is about constipation. How do patients with sluggish colons and chronic constipation get stool moving through the colon? And I have to say, this is something that comes up in my clinic all the time.
Yes, and I think that there's a question for you later on in the evening, so you can maybe speak a little bit more to that later on. But I do also see patients with constipation in my clinic, although surgery is less commonly indicated for these patients. But I think there are simple things that everybody can do, at least to start, and that's things like taking over-the-counter stool softeners. Miralax is what I typically recommend to patients. Increasing the fiber in your diet, and consider taking a fiber supplement like a Metamucil or Citracel, or there are lots of them over the counter. Drinking lots of water, and then using a stool or a squatty potty or something to prop your feet up while you're having bowel movements to help relax your pelvic floor and relieve any straining that might be happening with bowel movements. And then, as I mentioned before, keeping a food or bowel diary to decide, are there foods that reliably will worsen constipation or will, on the other hand, give you diarrhea? So kind of figuring out what are your patterns, and are there things that you can avoid as triggers for disruptions in your bowel habits. If those measures don't work, then that's the time to seek care either from your primary care physician or a gastroenterologist, or again, in select cases, coming to see a colorectal surgeon. And we think about constipation as being in sort of two large buckets, one being abdominal constipation, where, as the person who wrote the question said, a sluggish colon. And so abdominal constipation being where the colon or the other intestines just don't move very effectively. And so need some help with either medications or, again, sometimes with surgery. Or we think about pelvic constipation, where the pelvic floor or the muscles around the anus and the pelvic floor don't work appropriately. They're not coordinated or are weak in some way, and so can't effectively push stool out when you have a bowel movement. And we treat those two different buckets of constipation, abdominal and pelvic constipation, differently. And so when you come to see a provider or specialist, we may order additional testing to determine which kind of constipation are we dealing with, or is it a mixed picture? Things like getting a colonoscopy to make sure there's not another or some other pathology that's caused the constipation or change in bowel habits, or other studies to determine the strength and coordination of your pelvic floor, or whether your colon is just sluggish or taking too long to get stool through. And then the treatment for it may involve stronger laxatives than the over-the-counter things that I mentioned, and that would be something like the Dr. Garg or a gastroenterologist specializing in motility might prescribe, and she can speak to that later on with that question. I sometimes refer patients to pelvic floor physical therapy to help with pelvic floor coordination and strength to improve the effectiveness of the pushing with bowel movements. And then again, very rarely patients require some kind of an operation to fix their chronic constipation, but we try to save that as a last resort if those other measures don't work.
Thank you so much, Dr. Gunter. And in a little bit, I will follow up on some of the medical treatments that we have for constipation, different over-the-counter therapies and prescription therapies as well, which was one of the questions that came up. But first, for Dr. Papouras, should certain foods be avoided to minimize GERD symptoms?
Yeah, so typically when we see patients, they complain of tomato-based type foods or more acid foods that will bring about their reflux symptoms or their GERD symptoms. So we obviously recommend patients to avoid those types of foods. And each person will have, as discussed with other topics, have their own certain triggers that will bother them. So once they figure out what those foods are, keeping a diary, as mentioned, really is helpful for that. And trying to minimize and avoid those types of foods is really helpful.
Perfect. Thank you. So obviously diet plays a big role in reflux, metabolic liver disease, constipation. So I think those are some of the themes that you're seeing in this conversation so far. So next is for Dr. Wakim-Fleming, back to liver disease and diet again. For patients with high liver enzymes, fatty liver disease, or also called metabolic liver disease, any preference for the liver diets that are out there? And I know you said the Mediterranean diet, but anything more you can say about diet?
Yeah, so any diet where the patient can, or the individual can help treat the underlying cause for the liver disease is a good diet. Mediterranean diet has been studied over and over and over many times, and it consists of unsaturated fat, less red meat, more vegetables and fruit, olive oil, more fish. And now there is something we call the green Mediterranean diet, where there is more vegetables and less meat or saturated, and more of the green tea, 3 or 4 cups of tea. I also want to say, I tell my patient to drink tea or coffee 3 to 4 cups a day, because these have shown to help the inflammation and the liver. But we are doing more personalized care, so there is no one diet, and I say you should do that. They see the nutrition, and they'll bring their diary, what they eat and what they drink every day, and they have their diet tailored to that person to become, it's a more personalized diet.
Thank you, Dr. Wakim-Fleming. And I may follow up after that, since we're on diets and treatments for common GI and liver conditions. So one of the questions we received is, how do you relieve or treat chronic or constant constipation? I would say this is probably one of the most common concerns or issues that a patient comes to us with in a GI or gastroenterology clinic, along with heartburn and some of the other things we've talked about. Constipation is one of the most common issues that patients have. And so in that sense, I think if you out in the audience are suffering with this, one thing you should know is that you're not alone, because a lot of patients suffer with this, and everyone's different. Some people have mild symptoms, some people have more severe symptoms. But one of the main things that we talk about in our clinic, and again, we have a collaborative clinic, we have surgeons, we have nutritionists, we have GI psychologists, but one of the main things we talk about is nutrition. So diet and behavioral changes are sort of at the forefront and the foundation of some of the treatment strategies and management for constipation. So when it comes to diet, two of the main things we talk about are fat and fiber. So getting about 20 to 25 grams of fiber in 24 hours. So the other way I explain it to patients, like I did today in clinic so they can remember it, 24 grams in 24 hours. So 24 over 24. So getting enough fiber in there. But fiber doesn't mean that you can just have some vegetables during the day and maybe a few nuts and seeds, and that's it. So you do need a little bit of fat in your diet, and ideally about 3 meals a day, because that stimulates what we call peristalsis to help your GI tract move. The next thing is getting at least 2 liters of water a day, because a lot of these laxatives, the way they actually work is they're called osmotic laxatives. So they bring in water to your colon. So you can help that along, help your colon along by drinking enough water. So the nutritionist will talk about water, we'll talk about fiber, we'll talk about fat, and then behavior. So believe it or not, sleep plays a big role in how your circadian rhythm works and how you're able to have a bowel movement, which usually the best time is in the morning. So getting a good night's rest, cannot emphasize that enough. So getting a regular schedule, regular routine, some activity. So if you can, even walking 30 minutes a day. The most important thing is routine and consistency, trying to do it most days of the week. So that means 4 to 5 days of the week. And last but not least are different medications we use. So we have over-the-counter medications. So as gastroenterologists, we usually recommend fiber. So there are different types of fiber, but usually we recommend what's called soluble fiber. So the natural soluble fiber that's out there is something called psyllium, is usually what we start with. There's also FiberCon, Benefiber, Citrasil, and oftentimes we combine that with a mild osmotic laxative called Miralax. The reason we start with those is these are some of the safest medications that are out there. They've been studied for decades, and we even use fiber and sometimes a very mild osmotic laxative, even in some of our pregnant patients. That's how safe they are. So usually we start with that. The other reason I recommend these medications is they're powders, meaning you can put a little extra powder in your drink or oatmeal or put a little less. So you can titrate that. So that's a nice thing. Stimulant laxatives, everyone's different. We usually don't recommend that off the bat or on a very regular long-term basis unless you have severe symptoms. And last but not least, you should definitely see your gastroenterologist if, despite some of these dietary measures, over-the-counter medications, you still have constipation. You may need to see your gastroenterologist to see if you'd be a candidate for prescription medications. And we have a variety of prescription medications out there that patients that may help many patients. So that's kind of an overview of management and treatment options for chronic constipation. So we may have time for maybe 1 or 2 more questions. So Dr. Gunter, what is the difference between Crohn's and colitis? And I know that's a big topic and a little different topic from what we talked about, but could you please summarize the difference between colitis, also known as ulcerative colitis, and Crohn's disease?
Sure. So both of those conditions, ulcerative colitis and Crohn's disease, are captured under an umbrella term that is inflammatory bowel disease, or IBD. And so there are the 2 forms of IBD, the ulcerative colitis and Crohn's disease. And they have some overlapping features, but generally ulcerative colitis only affects the colon, or is inflammation within the colon. And Crohn's disease can affect the GI tract from the mouth to the anus. Both of those diseases can have what we say are extra-intestinal manifestations, or things like skin rashes or joint pain or other things that affect the body outside of the GI tract. But in sort of thinking about big picture, like I said, ulcerative colitis is only in the colon. Crohn's disease can affect any area, and including perianal disease with fistulas or abscesses. That's much more common in Crohn's disease than in ulcerative colitis. Crohn's disease affects the entire wall of the bowel, either the colon or the small intestine, whereas ulcerative colitis only affects the mucosa or the inner lining of the colon. The classic picture with ulcerative colitis would be that it starts in the rectum and then progresses continuously throughout the colon. And in Crohn's disease, you can see what's called skip lesions, or areas of the bowel that are affected, and then there are unaffected or normal bowel, and then there's other areas of disease. We call that skip lesions. And then there is, like I said, Crohn's disease can affect the entire wall of the bowel, and so you can see what are called fistulas, where the disease penetrates all the way through the wall of the bowel into other organs or other parts of the bowel. Or you can get areas called stricturing or narrowing related to the full thickness inflammation of the bowel. Both of those diseases, like I said, have overlap. They're treated by gastroenterologists with medical management with a variety of different medications, and more of them are coming on the line all the time. I myself have a hard time keeping up with all of the new therapies that are being developed for Crohn's and ulcerative colitis. And then some of those patients will require an operation during the course of their lifetime, either to remove or treat the areas that have the disease. Patients in both of those populations should have regular colonoscopies because they are at increased risk for developing colorectal cancer. And so that's a very important part of their preventive care, is to stay up to date with their colonoscopies.
Thank you, Dr. Gunter. And as a follow-up, anything you would like to mention about treatments that we have right now for Crohn's disease or ulcerative colitis? As a final question, as a follow-up to your previous answer, what would you say about treatments for Crohn's and colitis? I know that's a big and broad question.
It is. So because both of them are inflammatory diseases, all of the treatment, the medical treatment, is about modifying the inflammation and the immune response to the bowel. And those can be things like steroids. It can be oral immunomodulators, things like Asacol or mesalamine. And then there are an increasingly large group of medications called biologic therapy that target various parts of the immune system. And those are typically given in either injections that can be done at home or are done in an infusion center at regular intervals, typically either once a month or every 2 months, depending on which medication and the severity of your disease. And again, more and more of those are coming online all the time. There are several researchers within the Cleveland Clinic system who are developing new medications all the time. And then there are often trials that are ongoing. And then surgery is for patients who fail medical management or who have ongoing symptoms despite being on maximal therapy. And so that can involve, for ulcerative colitis, removing the colon and the rectum and either giving a patient an ostomy or a bag on the outside, or doing other procedures to restore continuity, where we can using the small intestine, create a pouch or some other reservoir and connect that to the anus so that a patient can avoid a lifelong ostomy. And then Crohn's disease is a little bit more challenging because it can affect, like I said, any part of the bowel from the mouth to the anus. And so there are a variety of surgeries that are involved in treating Crohn's disease, depending on which part of the bowel is affected.
Thank you for that summary of Crohn's and colitis. We probably have a lot of questions about Crohn's or colitis, but the nice thing is we have a IBD center. So if it's something that patients struggle with, whether it's Crohn's or colitis, we have gastroenterologists, we have surgeons. We also, again, have nutritionists and other specialists that work in that center. And one kind of related question I always get is about IBS and IBD. Again, these are two very different conditions. We talked a lot about irritable bowel syndrome, or IBS, which is more having to do with what we call neuro-GI or GI motility functional disease. And then Dr. Gunter just did a nice overview of Crohn's and colitis, which is IBD, or inflammatory bowel disease. So I think that's about all we have time for today. So this concludes our Cleveland Clinic Ask the Experts event. Thank you all so much for attending and all of the questions. We really appreciate them. Sorry if we didn't get to your question, but hopefully we answered some of your questions. We will send you a post-event email in the next day or so with important information about what you just heard, links to all kinds of digestive health resources and details on how to make an appointment, along with the phone number as well. It will also include a link to a recording of this event so you can view it again. Thank you and good night.